So hello again, and this time we're going to be talking about acute lymphoblastic leukemia. So acute lymphoblastic leukemia is important to know about, partly because it's the most common cancer in childhood. Not just the most common hematological cancer, but the most common cancer. So if you're a pediatrician, you will come across this, and even in general practice, you will come across it from time to time. At an incidence of 5 per 100,000 per annum in the high-risk age group, which is 0 to 4 years of age, we're going to see this more than once a year in Wellington. It is much less common in adults, but it does occur, and in hematological practice, definitely we see this from time to time. What causes acute lymphoblastic leukemia? And the bottom line really is that we don't know. After much study, it isn't very clear. We do know a couple of things. We know that it is increased in incidence in some congenital genetic disorders, and Down syndrome is one of those. It's also something that can complicate, surprisingly, chronic myeloid leukemia. So the usual transformation of chronic myeloid leukemia is into an acute myeloid leukemia, but in some cases a chronic myeloid leukemia can transform into an acute lymphoblastic leukemia. This is a bit of a recurring theme in hematological malignancies, that not only do the malignancies overlap a bit, but what can happen is one malignancy can transform into another. And again, this is part of that hemopoietic diagram that I keep showing you, just to show you where the ALL tumour cell arises from. It's somewhere between the stem cell and the differentiated B and T lymphocytes. So ALL can be either B or T lineage, but it's not a mature cell. It's a precursor B or a precursor T cell. So it's probably worth spending a little bit of time on this slide, because this is how ALL presents clinically. A very common presentation is with bone marrow failure, and bone marrow failure is really something that you do need to know about and understand, because it's a common presentation of a number of malignancies. It's also what you will be dealing with and managing if you are a junior doctor working in a hematology ward. So bone marrow failure, we're talking about anemia, we're talking about low neutrophil counts, so putting people at risk of bacterial infections, and low platelets causing bleeding and bruising problems. With ALL, another really common presentation is bone pain. But the high-risk population, the highest risk population, is young children aged 0 to 4. So they often don't tell you they've got bone pain. They might just not use a limb or be limping on that limb. Being a lymphoid malignancy, it's not surprising that we can see enlargement of the lymphoid organs. So we might see large lymph nodes, we might see large liver and spleen. And the other thing about ALL is it can get into the central nervous system, where it often causes headache, cranial nerve palsies, and it can also get into testicular tissue and causes testicular swelling. And the issue there is if you don't look, you won't find it. So very quickly again, just to hammer home that bone marrow failure is important to know about: anemia, neutropenia, thrombocytopenia, with a big star to make sure you remember it. To give you just a little bit of a flavour of how ALL does present, this is a very brief case history. So a 3-year-old boy who's recently developed a limp, and he might also have bruising. And he may present to A&E. He might present to pediatrics, he might present to orthopedics or his GP. And if a blood count is done, it's very likely that this is going to be abnormal. And in this case, it's abnormal in many ways. So the boy is anemic, He's got neutropenia, he's got thrombocytopenia, and he's got a high white cell count because he's got primitive cells in his peripheral blood, blasts. And the picture below is of lymphoblasts that we see in ALL, and they're largish cells with open chromatin, which is a characteristic of a primitive cell, and they have relatively small amounts of cytoplasm which isn't granular, which is a characteristic of lymphoblasts. A particular presentation of T lineage acute lymphoblastic leukemia is with a mediastinal mass due to thymic enlargement. And sometimes that mass can be big enough to cause superior vena caval obstruction, which might present with facial and arm swelling, worse in the morning, dilation of veins in the head and upper chest, dyspnea, and headache. And if you see that, that is something that you need to take urgent notice of, because potentially it can cause respiratory obstruction. So we've talked about how ALL can present, which will raise suspicion of this condition, but in order to actually make the diagnosis, we need to do a bone marrow and show that there are more than 20% blasts in the bone marrow. And we also need to make sure that we have diagnosed what sort of blasts they are. This is just a picture of lymphoblasts in the bone marrow, and these have got a particular appearance that is quite typical of some ALLs, which is sometimes referred to as a hand mirror cell. So there's a bit of cytoplasm sticking out at one end of the cell. So morphologically we might be suspicious that this is ALL, but it's not enough to clinch the diagnosis. We need to prove that the blasts are lymphoid in origin by looking at the antigen expression on the cell surface. So we do this usually by flow cytometry, detecting antigens on the blast cell surface. And the things that make us know that this is ALL are a combination of early antigens. So there's an antigen called TDT, which is a DNA polymerase enzyme that is present in early lymphoid cells, T and B cells, and CD10, which is an antigen that's present in slightly more mature precursor cells. So those antigens will tell us that these are early lymphoid cells. And then we will be looking for B lineage antigens such as CD19 and T lineage antigens such as CD3. We look at more antigens than this, but this is just to give you the principles of immunophenotyping. And by now you'll probably already be expecting this slide, because after immunophenotyping, when we're looking at hematological malignancies, we generally do cytogenetics or molecular studies or both. And in ALL, we do cytogenetics primarily for prognostic information. So there are some changes that have good prognosis, so hyperdiploidy, too many copies of all the chromosomes, a 12-21 translocation, both of which give good prognostic information. On the other hand, bad prognostic cytogenetic features include having too few chromosomes, having the Philadelphia chromosome, which you will remember is the translocation that we see in chronic myeloid leukemia. But when we see it in ALL, it's a bad prognostic feature. And in infants with acute lymphoblastic leukemia, there's a translocation between chromosome 4 and chromosome 11 that tells us that this is a poor prognostic ALL. There are others, but I think these are the most important ones for you to remember. We said before that ALL can infiltrate the central nervous system, and in order to look for this, we always do a lumbar puncture and look at the CSF, the cerebrospinal fluid, under a microscope to see if there are lymphoblasts in the CSF. And if there are, We can immunophenotype them there and prove that they are part of the ALL clone, and that will tell us that the CNS is involved. So as usual, for a hematological malignancy, we gather prognostic information to give us an idea of what to expect on the progression of the condition. Poor prognostic features in ALL include being an infant, being an adult, carrying the Philadelphia chromosome, and having a high white cell count. Good prognostic features include hyperdiploidy and a low white cell count, and being a child over the age of 1 and under the age of 4. In addition, the outcome is generally a little bit worse for males than for females. So I'm not going to go into details of treatment of ALL. There is some information in the ABC and Hematology book that you can look it up. I don't think it's important that you remember details of treatment. But the outcome of treatment for children and adults is quite different, and that I think is important to remember. The 10-year survival figures for children give us a figure of about 90%. So the outcome for children is good. Most children with ALL will be cured. The situation for adults is different, and it's less than 40% of adults with ALL will have long-term disease-free remissions. So very different according to which age you develop the acute leukemia at. So in this short talk, I hope that we've covered how ALL presents, who gets it, what sort of presentations might make you think that someone has acute lymphoblastic leukemia, and how we diagnose it as hematologists in the laboratory. And also, I hope, some idea of how people are likely to fare with this condition depending on whether they're adults or children.